Optimal health for high performers. This is the Health Upgrade Podcast with Dr. Nawaz Habib.
Hello, everybody. Welcome back to the Health Upgrade Podcast. This is Dr. Habib. I'm here with JP. How are you?
Doing fantastic.
Wonderful. And we have an amazing guest today, Dr. Matthew Antonucci. Great to see you, sir.
Hey, thank you so much for having me. I'm excited.
So, Matt, you and I, you had me on a few panels at the Florida Chiropractic Association a few years ago when I kind of became the vagus nerve guy. And we were talking a lot about concussion and talking a lot about brain retraining. And you have a history and kind of background on the chiropractic neurology side of things. I'd love to hear about what brought you into that world. I know it was, I know the story of you and your father-in-law meeting, which was kind of a nice one, but would love to just get the basic overview of how you got into chiro neuro.
Sure. My biggest thing was I saw so much potential in chiropractic from the get-go, even as a patient way back when. I wasn't one of those individuals that had a grandfather who was a chiropractor and a father that was a chiropractor. So therefore, my whole family had no idea what chiropractic was. When I said, hey, I want to go to a chiropractor, like, what is that? And then when I said I wanted to become a chiropractor, like, why don't you become a real doctor? So, and the chiropractors will get that one, right? So, and it's the misunderstanding that's out there. But what made me want to become a chiropractor was the results that I saw from chiropractic. And they weren't like my back pain went away or this. My allergies went away. My headaches went away. Things that were completely non-musculoskeletal got better when I was under chiropractic care. So when I went to chiropractic school, that's what I wanted to figure out. I wanted to figure out how is it that manipulating a joint or a muscle, because it's either a joint or a muscle that we're manipulating, it's not always just a joint. Manipulating a joint or a muscle can actually change something that would be deemed to be neurological or immunological. And to be honest with you, I wasn't getting that answer in chiropractic school. So that's where, I had a very great opportunity to be schooled at Life University, which one thing about Life University, and still to this date, they offer their students so many options in continuing education where you can study anything you really want to in the field of chiropractic. So one of the things that came up was we had the opportunity to study functional neurology or chiropractic neurology. So I dove into that headfirst, and that's how I kind of discovered the whole chiropractic neurology thing.
So
That's
I have
amazing.
a question, and I think it's probably a question that many people in our audience experience. And I kind of know the answer, but I'm not a chiropractor, so I want to ask you two, both of whom are, to really maybe give for our audience who don't understand all of the history and nuances, and we don't have to go into the details of it, but you've got allopathic medicine, you've got osteopathic medicine, and you've got chiropractic, what I'll call medicine, chiropractic.
Yep.
And all of them existed sort of equally in sort of stature for centuries. And then something sort of changed in the late early 1900s. And all of a sudden they became sort of different tracks. And you said, bringing it back to the point of manipulating the musculoskeletal system was having effects on the immune system and on the nervous system. Tell me how all of those pieces sort of fit together, and tell the audience sort of how they should think about chiropractic, because I know that I don't think of chiropractic as something that's lesser. I think of it as sort of the original functional medicine, the original biohackers, the original people who figured out connections that maybe the rest of the world hasn't even seen yet.
That is brilliant. And it does go back a long time ago. You can find evidence all the way back to Asia and Oriental medicine of manipulating joints, right? And why they manipulated them, who knows? We can't get inside their head in that days and try to figure out why. But one of the things that we do know is that, as you kind of said, all of these different healthcare systems kind of walk together. And osteopathy and chiropractic, A.T. Stills and B.J. Palmer and D.D. Palmer, one is the founder of osteopathy, one is the founder of chiropractic. They learned from each other. They just had differing opinions of how to do it. For example, you look at osteopathy. I'm on faculty at the Orlando College of Osteopathic Medicine, and I'm a chiropractor because there's so much similarity between the two. Mm-hmm. They love the perspective to be shared. They all have to deal with this flow of something, right? They they call it the tide inside of osteopathy, where it's like a flow of some sort of energy. And chiropractic talks about a flow of intelligence from above, down, inside out. And all that flow came from this Galilean sort of thing. Galen, who was the physician for the gladiators, he basically saw when these people's head got lopped off and he would study their brain, he would see that the pituitary gland kind of sat at the top of a tube that was filled with a clear fluid, which we now know as CSF fluid. And he thought that basically flowed through the spinal cord into nerves and inflated muscles, right? So that's how muscles became activated. So that flow model persisted all the way to like the early 1900s, where like Luigi Galvani and Volta and some of these different people discovered electricity and animal electricity. And now, to answer your question, how is it that manipulating the musculoskeletal system can affect the immune system? Well, there's a clear answer to that. There's one clear answer. It's the intermediary portion, which is the brain.
Yeah.
Right? So we know that muscles don't just move, they also sense. And it's all based upon electrical signaling that we know of right now. There are some individuals out there that are suggesting that actually the nervous system communicates on sound waves, which there's a big group, not like flat earthers or something like that. There's a group of people that have a fair amount of evidence that suggests that it's actually sound waves that travel bidirectionally up and down neurons that kind of create this. And that when we have shift of ions and there's sound waves, like almost like thunder and lightning sort of thing. Yeah, there's a whole bunch of principles. We know for sure that the way the brain works is it perceives the environment, interprets it, and creates a response so that we can survive. That's the real reason why we have a nervous system. And there's nothing that happens in your body that's not like input, interpretation, output. Pick any output that you want. Pick blinking your eyes, beating your heart, peristalsis in your gut, sweating on your glands, standing up of your hairs when you're scared. All of those things originate from a sensory input. So when we start looking at how does chiropractic create immune outputs, well, it's simply you're just changing the input, and it can make the immune output worse. It can make it better, but it's going to have an effect no matter what.
It's great that you talked about Galen. We don't talk about Galen much on this podcast, but I will tell you, Galen, what a giant in the field of medicine. I mean, to the extent that at 200 AD, he was able to discern where creativity existed in the brain. He recognized that the prefrontal cortex and the frontal cortex was where you had creativity. I mean, maybe, and really all he had to do was observe people like going, oh my God, I had a good idea by banging the front of their head. But I mean, I'm joking, of course, but when you think about the influence, 1,500 to 1,700 years of his biology and his anatomy and his understanding of how the body works dominated, and still to this day has impacts on people. It's in our language, because you were talking about the fact that fluid that he said flowed through the nerves. We have it in our language that when something makes an impression on you, it's literally because he thought that it was impressing on the nerve and the nerve was deforming, and that was sending the signal up to the brain. Yeah. He then also, when somebody is really, really has strong-willed and fierce, we say they have nerves of steel because the pressure was high in those nerves.
Yeah.
So it's pretty amazing. Pretty amazing.
It really is. And, one of the other things that he also did is, he did do with the nerves, but he also did the same exact observation with the cerebral cortex, where he took his fingers and he pushed his fingers into the cerebral cortex, and his fingerprints were left inside of the brain. And he says, well, that cerebral cortex must be where we have memories and impressions, like you said. And then he palpated the cerebellum, and he said, that's hard like a muscle. So that must be where muscles are controlled. So, I mean, it's kind of like, I always kind of tell this story. He was 5 years old at the time, but my son goes, hey, Daddy, why does the tree make wind? Right? And we sit there and we laugh, but it was an observation that he saw this with the leaves and he felt wind on his face. And he thought the leaves were creating the wind on his face. It's almost like, sticking your fingers in. Hey, but he was right for the wrong reasons, but still brilliant in his observations.
Yeah, that makes a lot of sense.
We think we're so smart nowadays because we've got electron microscopes and quantum computers, but it just takes us away from the art of observation.
Oh,
and these
absolutely.
people did amazing things simply by observing.
Yeah. And, it's kind of like that is what we try to emulate today. my mentor, Ted Carrick, he basically tells us that you should be able to help somebody with nothing more than your hands and your eyes, right? So you don't need fancy technology, but you need to be able to make observations and you need to be able to affect somebody. If you can observe and affect somebody, you can change and cure somebody with your hands and your eyes, which, I mean, that was original medicine, right? It's just, they didn't have, special tools. They didn't have MRIs or CT scans. They would just observe and then treat. And then, the father of the physical examination, at least the neurological examination, was Charcot. So he was the administrator of the Salpêtrière Hospital in Paris, which was an insane asylum. And he would look at all of these people that were crazy and realize that when he would perform a physical examination, that he can recognize neurological signs. And he was because this was the Freudian era, right? And he was the first person to say, hey, the brain is not separate from the mind. They're all one thing. And if we affect the brain, we can affect the mind.
I love that point that you brought up there. I just want to tie kind of an end to this part of the conversation. But JP, you asked earlier, what kind of caused the separation between chiropractic, medicine, osteopathy, and how that all occurred. And I think it was just these philosophical views that ended up shifting how we thought about the body. And where medicine kind of went was there's this system and there's that system and there's the other system. And they started separating the body out and creating partialists. Exactly. And what chiropractic, I believe, in my opinion, has done is remained in a very holistic view of the body, that all of the systems work well with one another. And Matthew, to your point of sensory inputs, how our body interprets those, and then the output that flows, whether it's immunological, whether it's neurological, whether it's muscular, whether it's digestive, whatever it is, it's the input and the interpretation is going to change because the new input is being put in via the sensory system. So I think that's where functional medicine now, and this idea of driving towards bringing us back to the whole view of a person and the fact that all of these systems are working well together, we're realizing that overly separating out the body into separate parts does not help that person to heal and get better and actually thrive. That's where functional, and I like to kind of say that functional medicine is a chiropractic mindset and a medical model. It's a very way of kind of seeing it. That's how I've been talking about it for quite a while now.
That's exactly right. And I think you guys have, instead of having to use pharmaceuticals, which is what medicine is all about, and I would argue that there was a profit motive and, pharmaceutical petrochemical influence that drove some of that separation away because they wanted to sell something. But I think chiropractic, you guys have the argument of saying we used the most sophisticated equipment in the history of the universe in treating patients because we use the patient's brain. We use the patient's nervous system. We use the patient's musculoskeletal system. We influence the immune system and metabolism at the cellular level. That's way more efficient and way more sophisticated than what medicine is doing with their blunt chemicals.
The thing is, I want to challenge you guys to think one level deeper than that, because it really is not holism and reductionalism. It's the ability to switch back and forth between the two, right? So that if you're a reductionalist, you don't see the big picture. If you're, I don't know if the word is a holist, I don't know what the word is, but you don't see the pieces. We have to really
splitter. Lumpers and splitters.
Yeah, but see, the thing I always tell my patients is, listen, because I treat mostly concussion, works really well. Humpty Dumpty fell off a wall and he broke into all of these pieces. If I examine the pieces, I have no idea how to put them back together unless I know what Humpty's supposed to look like as a whole.
Agreed.
Right? So we really have to look, good practitioners. I don't care what type of practitioner you are, medicine, chiropractic, naturopathy, acupuncturist, massage, it doesn't matter. You have to be able to zoom in and zoom out, zoom in and zoom out, because realistically, that's what it is. And the whole thing even with medicine and non-medicinal approaches, there's benefits to incorporating medicine at certain points, and there's benefits to incorporating physical modalities at some point. And sometimes it's good to put them both together. So my encouragement to all of my students is don't live in any one box. Be nimble. Be the person that's outside the box and step into whatever box you want to, but don't live in a box.
Yeah.
And that's how you help your patients the best.
If we get overly dogmatic as clinicians, then we are doing a disservice to society, to our profession that we are kind of lumping ourselves into and cutting ourselves off from the rest of it. I love that you're talking about this interplay and the ability for practitioners of different types and different philosophies to come together and work together.
Yeah.
That's incredibly important. And to shift the conversation a little bit now towards the chiropractic neurology side, understanding where you came from on and became kind of the guy on concussion, TBI management, and how to understand the effects of this, and then to dig into this vestibular issue that is heavily linked to autonomic dysfunction. Let's talk a little bit about some of those initial observations and some of those initial stories that you started to see that concussion, TBI, and vestibular issues played a role in affecting the autonomic component.
Oh gosh, yeah. I mean, it doesn't even have to be with concussion patients. You can make this observation at theme parks. People get spun around, they throw up.
Yeah, those teacup rides.
There's the connection right there. We know that when the structures in our inner ears, the semicircular canals in the otoliths, when they become stimulated asymmetrically, one side more than the other, we create action potentials that travel up that vestibular nerve and they integrate into the brainstem. Where they integrate, we have our vestibular nucleus, and there are all sorts of physical, I'm not making things up. These are anatomical pathways that can be traced out with rabies markers and all that kind of stuff. There are anatomical pathways that go from that vestibular nucleus to the nucleus tractus solitarius. Right. And we also have it to the dorsal motor nucleus of vagus. Right. So these are hardwired pathways, and there's nothing in between those pathways. So there's direct reflexes. So when we talked about input, integration, output, there are different levels of integration. We have spinal cord or brainstem level integration, then we have midbrain integration, then we've got cerebral cortical integration. So the higher you go up the building here, the more complex the integration is. This is a very, very simple reflex, right? So if somebody has a concussion where let's put it this way, nobody ever damages their inner ear with a concussion, unless you take a baseball, lacrosse ball, hockey puck to the ear, right? Where you develop a vestibular contusion or your skull fracture, something like that. 99.99% of individuals that have a concussion don't injure their inner ear. They injure the integrating center. They injure the brain, right? So what that basically is saying to us, I always tell my patients, you've got a microphone, an amplifier, and a speaker. The speaker is your body. Like that's where it's going to be communicating to the world. If the microphone is working just fine, but the amplifier volume is way too high on one side, way too low on one side, you're like, plug in your ears because you don't want to listen to the music coming out of that. It sounds so imbalanced. Well, you plugging your ears is analogous to having some sort of an autonomic reaction. Now, the important thing to remember about the autonomic nervous system is that autonomos means self-governing, right? It does what it wants to do when it wants to do it, and you really have no control over it other than the stimulus that you provide to it. That could be an electrical stimulus. It could be a physiological stimulus like spinning in a chair or something like that, but it does what it wants to do. As a matter of fact, going back to Galen talked about how the sympathetic nervous system, the way it actually worked is it worked in sympathy with the other part of the nervous system. That's why there is this duality between your nervous system and your autonomic nervous system. There is no such thing as an autonomic nervous system. It's all one nervous system. We have an autonomic network inside of our nervous system, but there is no autonomic nervous system. This is, once again, a contribution from the past where the autonomic nervous system reacted in sympathy to the rest of the nervous system. That's where the sympathetic nervous system got its name, right? So when we start looking at this, we have to understand what triggers the autonomic nervous system to do what it wants to do. And the old model of the parasympathetic and sympathetic, that doesn't make any sense. It really doesn't, because it's not like when sympathetic goes up, parasympathetic goes down and vice versa. If that were to happen, you would eat and pass out, like literally physically pass out, because your blood pressure would drop so much that you wouldn't have any circulation to your brain, because rest and digest slows your heart rate, decreases blood flow to places, or, and just to kind of make it even a little more, I guess, poignant intercourse. We have to control plumbing there, like point and shoot. That's what we call the parasympathetic and sympathetic. So like, what is it? Do you point or do you shoot? Right. And there has to be this agility for our nervous system to be able to activate both of those networks simultaneously. And the big question is, why does it do what it wants to do? And when you do all of your studies and all of your reading, what you're going to figure out is it all has to do with one word. And that one word is called error, right? So if there is error, either perceived or not perceived, you're going to increase the sympathetic tone. The less error that is there, the less sympathetic tone you have. So that's kind of like a very broad generalization, but is held true for everything that I've seen in clinical practice. And what does error mean?
Yeah, well, we use the analogy of you have homeostasis, which is sort of like that centering, and then you have external and internal events that will push you out of that centering position. That's when the sympathetic nervous system responds to a threat to homeostasis by pushing you in the other direction. It's just automatic. It's going to push you in the other direction, but it doesn't know to stop.
Right.
So it will continue to push you farther in the other direction. And so, the simple mechanical parallel to getting a concussion, and you have vestibular problems with the signaling and the interpretation of the imbalance, if you will, is you fall over. But everybody's had the experience. What do you do when you start to fall to the right? You push yourself to the left, and you push yourself to the left so far that you end up landing on the ground. So it's that error and attempts to minimize the error, to respond to the error that lead to the problems. Because if you feel like you're falling to the right and you don't do anything, well, you're probably unconscious.
Yeah, absolutely.
What does error mean in your sense there? Like you were talking about error. Are we talking about perception of error? Is there a perceived outside of balance state? Where does error fit in that?
Yeah, that's a really good question, because remember I said it could be perceived or not perceived. And what I mean by that, let's start with perceived. That's an easy one. So, it's funny how some of these words and the English, I guess, language come together. When you say something makes sense, what does that even mean? It means that what I see and what I hear and what I smell and what I touch and what I feel all agree. It makes sense, right? So when something makes sense, there's no error. It doesn't. And then that's at a level one. Then a level two is, what do I perceive and how do I compare it against what I've been exposed to in the past, right? So for example, you can see, smell, hear, touch people. And if you live in Central Africa where people wear no clothes and they've got the bones that go through their nose and, most people are dark skinned, all of a sudden this white boy comes up in a blazer with a t-shirt. You're like, whoa, there's something going on here. This
doesn't make sense.
Yeah, this is different. I'm seeing, smelling, hearing, testing something that just doesn't resonate with my past experience. And your autonomic nervous system goes, whoop, pupils get big, heart rate starts to elevate, heart rate variability drops down until your frontal lobe says, nothing to worry about here. He's human too, and he's not here to hurt me. And plus, he's a skinny little dude with a blazer on. He's not going to hurt anybody. Yeah, especially when you got your big poles that you can throw, whatever. So that's your perceptual. But then we start looking at sub-perceptual stuff. We start looking at things like gravity perception. Like right now, none of us are thinking about how gravity is pulling on us, right? So if you damage like the amplifier volume of one of your inner ears, and gravity is perceptually pulling more in one ear than the other, well, every time you move, there's going to be imbalance there, and that's going to be erroneous. Or you might develop a head tilt. Well, when you tilt your head over to the side because you feel like gravity's pulling you down to the right, so you tip your head to the left, now all of a sudden your neck muscles say, wait a second, your head's not straight, and your eyes are saying, wait a second, I have to turn to make things look straight. Generates error. And you might only feel good when what? You lay down, because gravity's not pulling anymore on that ear that's sending the information and that's being misinterpreted by the brain. And that's when your autonomic nervous system starts to get better. And we'll take it one step further. You lay down, you feel good, you feel okay. Now all of a sudden you go from a lying position to a standing position. Now gravity thinks that you're pulling over to the side, and you're going to start beating your heart, increasing your heart rate. You're going to develop postural orthostatic tachycardia syndrome, or POTS, right? And the question is that we all should be asking as providers, okay, so with that understanding, how do we fix that, right? And how do we fix it? Well, there is only one way to fix it, because the autonomic nervous system does what it wants to do. It's self-governing. We have to make the autonomic nervous system feel safe again.
You have to change the inputs.
Yeah, change the input. Now that input could be electrical, that input could be physical, that input could be chemical. there's a whole bunch of ways to skin the cat. But I think ultimately what we want to do, understanding what we're talking about, we want to create neuroplastic changes so the person doesn't need the electrical stimulation forever, or they don't need the chemical stimulation forever. They shouldn't need the physical stimulation for forever if we could develop neuroplastic changes.
Yeah, because you can recreate that balance. You can recreate where the inputs are matching to what the previous experience is. And so things make sense once again. And as they make sense, then we're not sitting in an experience of stress and driving heavily towards a sympathetic outflow rather than a parasympathetic outflow.
Yeah.
Yeah. We just need to learn that if something has changed, that you're getting 80% signal from the right ear and 70% from the left ear, and you used to get 80 and 80, well, you need to recalibrate the system that's interpreting that information, change the gain, if you will.
Exactly.
And now get back to the point where even though it's only 70% in one ear and 80 in the other, you're still going to experience, and by experience, I mean internally perceive balance so that you can function. And the brain does that really all the time visually, but it's a little different when it's your vestibular system because it doesn't typically experience changes or fluctuations in its inputs the same way we get with vision. We get it with vision, we get it with hearing, we don't get it with the vestibular system. So it's not used to plastically changing the way we need it to, but you just have to train it to do it.
Yeah, exactly. And I think you kind of hit the nail on the head there, and you may not even realize that, the nail you hit. Our brain is really good with tonic changes, not very good with phasic changes. So a great example of this are astronauts, right? Our brain reorganizes with constant stimulus. Neuroplasticity is an important part of astronaut training. That's why they have them in the G stimulators and spin them in circles, because what they're trying to do is say, ignore your inner ears, use your eyes, because if they don't do that, when they get up into 0G and they're floating, they have no graviceptive information, and up looks like down and down looks like up, these people become terribly anxious. They have, sometimes they have tachycardia, they vomit, all these different things. So
Space sickness.
Yeah, exactly. Space sickness. So we really just need to calibrate all these inputs in order for us to have a healthy autonomic response to the world.
So let me ask you a question, because I experienced this, and my daughter, who's now a freshman out of college, is in a biology class, and they do virtual reality simulators for experiments in labs instead of actually doing them the way we did.
Yeah.
So when she puts on a virtual reality headset, and I experience the same thing. In fact, when I go to theme parks, I can't go on rides where they show you one thing, but they put you physically through something that doesn't quite match with what you're visually experiencing.
Yeah.
That causes me to have a great disturbance. Now, the signal isn't imbalanced. The signal is just not equivalent to what I'm seeing.
Yeah.
What I'm seeing, and so it doesn't make sense, or it's not, here's the other term that we use, it's not coming together.
Right.
My brain isn't coming together. The senses that I'm seeing and or what I expect, the expectation I have as to how I'm going to experience what I'm seeing and what I'm actually feeling are different. Gives me a headache, makes me feel a little queasy, and that can last for an hour. For my daughter, it was far worse. She put on that virtual reality glasses and started doing a lab, and within 20 minutes, she had a horrific migraine, and she has never gotten migraines before in her life.
Yeah.
And that migraine actually put her out of commission for almost 3 days.
Wow.
And I was worried that she had gotten a almost like vestibular concussion. But tell me, from a professional standpoint, what's going on, and how can we maybe train her so she doesn't have that problem?
That's a good question, and that's a lot to unpack there. So we'll do it at a superficial level. May not be to your satisfaction, because we'll probably need another 15 hours in the podcast to really go through all of that. But there's two things. Okay, so I'll lead with the first one that'll answer your actual question. So there's some research that suggests that is a combination between physical sensation and personality. So individuals that have more OCPD, obsessive compulsive personality disorder, the perfectionists, the ones that like to have control, one of the things that they show is that they're hyper-connected in their brain, right? They can make association between things that some people that don't have that they can't. Now that becomes bittersweet because individuals who have that type of a personality trait, they're less tolerant of error. They're less tolerant when their bed's not made. They're less tolerant when the dishes aren't put away in the right place. They're just less tolerant to error because that's how they're genetically wired. So there's some research suggests that personality approach, that phenotype, predisposes people to have more of that inability to discern the difference between error. Now, that doesn't necessarily mean that that's what you have or your daughter has or anything like that.
Well, I'm gonna raise my hand. I get it. I understand what you're saying. It's like the little things that happen, grammatical errors that my kids make. They just it's like it's like fingernails on a chalkboard.
Yeah.
I get it. I'm there. I'm with you.
So that could be one component of it. The other component is that, that person might be dealing with some sensory imbalances other than the goggles. And, they're functioning at a very high level using 100% of their bandwidth to normalize the aberrant sensory inputs in a day in and day out life. And then now all of a sudden you introduce error, which requires more bandwidth because there's more noise in the system. So the signal noise ratio starts to change, and that then starts driving autonomic responses. So anybody who has that, and this is where I said you're going to be underwhelmed with my answer, what they just need is they need a full examination, a functional evaluation to figure out, what contribution to their neurological function does proprioception have? Does vision have? Does vestibular input have? Does, where is this system somewhat not miscalibrated, but overly biased? And usually where that is people, when they put on the virtual reality goggles, they're relying too much on their eyes and not enough on their inner ears. Because if she closed her eyes in the virtual reality goggle, I'm sure she's going to be fine, right? So that just tells you that the visual system is overly weighted, but that's typically because there's either a proprioceptive deficit or a vestibular deficit, but functioning just well as long as the vision is accurate to what the others are saying.
No, I think that makes a lot of sense. I think that's probably pretty accurate about me, and it's probably not accurate about my daughter.
In case she's listening, right?
Put like 3 different negatives in there.
I have 2 questions for you. I love how you approach that and I feel like this is a very functional neurology style approach, is let's look at all of the senses that are pulling information into the brain. We're looking at vision, we're assessing vestibular function, auditory function, sensation, etc., taste where necessary. We're getting all of these inputs in, and the brain's function is to pull all these together and make sense of all of these inputs and create a necessary and equal output based on what these inputs are.
An appropriate output.
Appropriate. That's the word that I was looking for. So appropriate is key. And so what role does the amygdala play in determining whether something is familiar or fear-based? And I think this is an important distinction. There's a very recent study that clearly showed that amygdala is not turned on by fear or doesn't trigger fear. It's familiarity. You're looking purely for familiar patterns. And when these patterns show up and they're unfamiliar, they create a response that mimics what we now call externally fear. And so what role does the amygdala play there, if that makes sense, or if that's part of that relay pathway?
Yeah, and whenever you read a study like that or review a study like that, you always have to, don't take it for face value. I'm not saying the study's wrong. It's probably right. But is it that the familiarity triggers the amygdala, or is it that the amygdala was activated under tonic inhibition of another area of the brain that was released from tonic inhibition by a familiar idea? This is what I mean by this. There's another nucleus in our brainstem. Anytime it's a brainstem, it's primal, right? It's primitive. It's called the parabrachial nucleus. And this part of our brain is like the ultimate cynic. It basically says every sensation that comes into your brainstem is going to kill you, right? It basically said, oh, that's going to kill you. That's going to kill you. That sound is going to kill you. That light is going to kill you. That touch is going to kill you. And it has an intimate relationship with the amygdala and the cingulate cortex. And every single time you sense something, you immediately think it's going to kill you, put you in a fight and flight state. And then the prefrontal cortex, largely the orbital frontal cortex, comes in and inhibits the amygdala so you don't have a fear response. And that then shuts off the parabrachial nucleus. But if you have a sensation that reminds you of something, it says you're not okay. Don't shut off the amygdala. I always use this because it makes people laugh. It's like I had this friend that was gigantic. He's like 6'4", like 300 pounds. And, it's like if I go to a movie theater, and my wife, when we ever go to a movie theater, she always sits with her hand on my leg, right? So hand on my leg is a sensation. That sensation goes into my brain and it says, okay, hand on my leg, who's sitting next to me? If it's my wife, shuts off the amygdala. If it's my big dude friend, it turns on that amygdala so I can go, get your hand off my leg, right? And it all has to do with those repertoires that are established from our experience. And this is where PTSD becomes so ingrained in an individual's brain. And I don't want to go down this whole other rabbit hole, but there are some, I'll call them technologies. It's not like a device, like neuro-linguistic programming and things like these technologies that are far more effective for PTSD because it doesn't make you walk down the pathway of trauma again, which creates neuroplasticity and creates the feelings and triggers your amygdala. But what it does is it reprograms the way you think. And then all of a sudden you dissociate feelings from what's real and not real. And then all of a sudden now your prefrontal cortex gets in and puts a block on that feeling that then triggers the amygdala, which then triggers the autonomic nervous system.
And we're talking right now about fear and emotional responses to things. But Lorimer Moseley, who's a great pain physiologist, he's out of Australia. He has a great talk. I think it's a TED talk. And he talks about an experience he had walking through the bush in Australia. And having done it 1,000 times, he felt something brush by his ankle, maybe a twig, whatever, and he ignored it. And it turned out that 20 minutes later, he was on the ground unconscious and had to be rescued because it had actually been a hyper-poisonous snake that he was very fortunate to survive from. Fast forward 6 months later, his brain now is thinking differently than the way it had been, because previously it had been, I've been here 1,000 times, something brushing past my leg, yeah, sure, it's a twig, I got a scratch, no big deal. Now he's in the woods after having nearly died 6 months later in the bush. Something brushes past his leg, and now it feels as if he's got, and he describes it as a white hot poker stabbing him in the leg. He's down on the ground, writhing in pain until somebody finally looks at him and says, it's a tiny scratch from a twig.
Yep.
And that's how the brain's neuroplasticity pathways and what you're talking about, where that parabrachial nucleus is saying, hey, that's going to kill you. And now it goes up to your prefrontal or your frontal cortex, and your temporal lobes are saying, hey, that is going to kill you.
Yep.
I'm going to make it really, really, really hurt.
Yeah.
So anyway.
And another example of that, the rubber hand illusion. Have you seen the rubber hand illusion?
Oh, yeah. That's a great.
So Navaz, so a guy sits at a desk, he puts his hand on there, they have a wooden barrier right here. And then they make him move his actual hand around the other side of the wooden barrier, and they drape it, and they put a rubber hand out, and they take his arm out of his sweatshirt. So his sweatshirt is on the rubber hand. So it kind of looks like this. And on one side of the wooden wall, they start stroking his hand with a ruler as they stroke the rubber hand with the other ruler. And every time they stroke the index finger, they stroke the index finger, the middle finger, so on and so forth. And they tell him the entire time, that is not your hand. It is a rubber hand. Do you understand that is a rubber hand? He's like, yeah. And then on the other side of the wood, you're observing it. And what they do is they take a reflex hammer and they tap his finger, the rubber finger, and his actual finger jumps on the other side of the thing. And they're able to tap every finger of the rubber hammer, and he develops a reflex in his actual hand on the other side of the wood. And then what they do is that after they take the reflex hammer, they get a carpenter's hammer. And they just touch it with the carpenter's hammer. And then the investigator saying, that is not your hand. It is a rubber hand. I would never, ever, ever hurt you. And then he takes the hammer and boom, and he whacks the rubber hand. The guy screams in agony. And of course, I'm sure if we had him hooked up to heart rate monitors and all that kind of stuff, we see. And that was just as a consequence of firing those pathways of his brain that thought that was real. And there was error there when that hammer came down and hit the hand.
They're doing this now with people who have phantom limb pain.
Yep.
So if you've lost your hand, and a lot of people who have phantom limb pain it's almost as if their fist is clenched and it hurts and it aches because of the fatigue of holding that tight fist. So what they do is they put the hand that's still there on a table, and they put a mirror. And so it looks as if you've got both hands that are functioning. And they make you make a fist with the hand you have, and they have you then relax it.
Yep.
And you see both sides relax. And when that happens, the pain goes away.
Yeah, I've had a couple patients like that. And interesting enough, the patients that I have seen, I think it was like 5 or 6 of them, amputees, they didn't complain of pain. They complained of an itch, right? So could you imagine, like, you get an itch in your back and you're like, hey, you go to your significant other, can you scratch my back for me? I can't reach it. Imagine if that was on a limb that's not there,
Yeah.
right?
Yeah.
Husband can't scratch that for you.
Yeah, scratch that in the complex plane.
Yeah, and that's what we did the exact same thing built off with our research. We gave the full body length mirror, and we just started scratching their good limb, and they saw us scratching the itchy limb that doesn't there, and the itch goes away. So yeah, it's pretty real the way our brain, once again, going back to where we started our conversation, takes information in, integrates it, and creates a response. And the response could be either motoric or cognitive.
I think that's so important for people to understand, and just to understand how like a functional neurology style approach is to understand all of these sensations, the integration of those sensations through the specific structures in the brain, and then creating a shift on that balance point to enable a more appropriate response to then be the output.
Yeah, and that's the cornerstone of functional neurology. You take that out of it, you're just practicing neurology.
Yeah.
And we are getting like really right to the edge of where cutting edge research in consciousness exists. There's a great researcher over in the UK by the name of Anil Seth. And Anil Seth, he's got a great book called Being You, but he's also got some great TED Talks, et cetera, about this understanding of how consciousness really comes together. And there's a whole line of research that suggests that actually the autonomic nervous network, as you describe it, and the vagus nerve is actually the root of consciousness itself, because it is providing your brain with an understanding of self. It's understanding the system that you live with. And consciousness and an understanding that there even is a self arises out of that need to monitor what is self.
Interesting. Yeah. There's a bunch of different discussion around that. I guess we'll never really know truly what it is, but it is pretty amazing. But the reality is that self has to do with embodiment, right? We have to be able to have the limitations of where we need to have agency over a corporeal structure that has defined limits, and that's how we define the difference between us and not us. And then once we're able to control that thing that is defined by a physical border, that's when we develop agency, and that's when we identify self-perception. So you can start to realize how individuals who have difficulty with sensory processing, whether that be, somatosensory, vagal input, whatever it might be, they lose themselves. I'm not the same person as I was before, or, I just don't feel anymore, or I feel like, I'm just not me anymore, right? And I hear that very often, especially with individuals with concussions, because they're high enough functioning that there are centers that are working just fine, but then you have deficits in those systems, those that define either where space is in relationship to you or you are in relationship to space. And then, of course, you also need to be able to feel your insides. If you don't have insular sensation, then what are you? You're just you just have a boundary, but you have no substance.
But it's interesting. It's interesting how we feel things inside our bodies differently from how we feel things that are on the surface of our bodies.
For sure.
If somebody puts a pin on your second knuckle, you're not going to confuse that with your third knuckle. You're going to know that's the location. Now, if you put 2 pins right next to one another, that you might not be able to differentiate them, but within reason, you're going to be able to pinpoint where that pin is pointing you. Okay. You can't do that with this portion of my liver is right where the problem is, or this is my pancreas hurts.
Well,
or,
you know why? Because you don't have to move it.
Right.
Yeah, you don't have to move it, and you haven't trained it.
It's a really big part of it.
It creates the circle. It creates the cycle. You don't need to move your liver, so why do you need to feel where it is?
So that's why we've never trained
proprioception. Yep.
Yeah. Interoception versus proprioception. Totally. And interoception, I think this explains how mental health issues are so heavily defined by this dissociation between brain or mind and body, right? And the lack of understanding of self or lack of information of self making its way up. We know that 80% of the signals on the vagus nerve are afferent. They're coming up from the organ. So for us to get that relay up, in fact, our brains have been designed and built out in such a way that we have a sensory cortex and a motor cortex that have a pure homunculus on them, that we're able to relay this exact cycle of sensory input and motor output information on for all of the proprioceptive muscles, proprioceptive structures, but not necessarily for the internal structures.
We use the analogies on this podcast to cars a lot. Okay. But this is one that I think is really interesting. And I've observed it in my kids as well. When you get into a car, you gain agency over the movement of the entire vehicle. Okay. If you're in the driver's seat, and you very rapidly start to know where the boundaries of that car are. I mean, I know you can't see where the tires are, but chances are pretty good that if you roll up to a stop line, you're going to put the tires right on that line. When you roll up into a parking space, you're not going to hit the car in front of you, even though you can't see your front bumper.
Yeah.
But you just know where the edges of your car, when you have it to turn to get out of a parking lot, you know where the corner of your car is. You're not going to hit that car. And it's not because you can see it. You're not sitting outside watching it. You don't have a disembodied visual view, but you still know. And that I think is fascinating, how we gain, even in a vehicle that we're controlling that's clearly not part of our bodies, but we know where the edges and boundaries are because we control it.
Yep, exactly.
I don't know what you're talking about. When I sit in the driver's seat, I'm one with the car. I love it.
Hey, I just thought of, while we were talking about this, I thought of a new name for your new book.
Okay.
A new vagus nerve book. What goes up must come down. Because when we started looking at that bidirectional communication of the vagus nerve, I think that's going to be a really, really important one that we started to talk about that. Yeah, so I figured I don't know. I was never going to remember to mention.
You're talking about gravity also, because we had a talk with Leah Elson about some work that she does with NASA, and talking about the need that the body has for gravity. We talk about the need to get back to temperature swings that are more natural, light, dark cycles that are more natural, getting interfaces with nature that are more natural. But the same thing is true of gravity. You need gravity. Your body breaks down in the absence of gravity.
Well, JP, it's the only constant on this planet. There's a lot of research about
Death
that.
and taxes.
Yeah. Well, even taxes can be avoided, but gravity can't. You get in trouble when you avoid taxes. But the thing is that there's a lot of research on that looks at gravity as a Bayesian prior that supersedes all other sensations. And when I teach people about the importance of this, it becomes more clear when we start realizing that as humans we need anchors, and we look at different anchors in our life. Some people like having money in the bank is their safety net, right? Like I feel okay and safe and anchored if I have money in the bank, because no matter what happens, I can pay for something. Some people look at other people as like they're significant to others. Oh, she keeps me grounded, right? Or he keeps me grounded, right? But the reality is your wife can leave you, your husband can leave you, you can run out of money, but gravity as a terrestrial being is the only thing that is always constant. When I mean constant, it's always 9.88 meters per second, right? And that's how constant it is. It doesn't change. And when it does change, because sometimes it does change in a very infinitesimal way with lunar cycles or whatever, some people that are super sensitive to those things can experience the changes, and they don't do so well with them.
That's where the term lunatic comes from.
Exactly. Oh. Yeah. And that's why more women give birth on full moons. That's why werewolves come out when the moon is full, So it's like gravity is intimately from when sperm meets egg, appropriate to be constant. And I think Navaz, I think you were there when I was talking about it. And it's one of the first times I actually talked about it. Is like, if you think about this, talking about conception, what direction do sperm swim? Up the fallopian tubes or up, or up the uterus, whatever. And eggs fall down the fallopian tube. So that's how intimately up and down in gravity is related to life on Earth. So when we start exploring things like Mars and all that kind of stuff with different gravity fields, we've adapted to 1G of gravity over millions of years. Sometimes people believe it's hundreds of millions of years if you trace it all the way back to like prehistoric jellyfish. But what's it going to be when we show up on a planet that has 1/3, I think it's 2/3 of the gravity of Earth or something like that? It's going to be a different experience.
100%. You're right on
Venus
point
is
there.
a better target, even though it's got that horrific atmosphere.
But
it's
like
exactly
sulfuric acid.
And then 50 times the pressure. But you build bubbles. I mean, you're going to build a bubble on Mars anyway.
Yeah.
But it's got the same gravity.
Yeah, well, it's easier to build a pressure bubble than it is to build a gravity bubble. That's for sure.
Yeah,
not to live in a centrifuge on Mars.
I'm going to go tweet to Elon that he should change his mind and switch to Venus instead of Mars.
I'm sure he'll listen.
This was an amazing conversation. We got into consciousness, we got into gut health, we got into brain and how we sense, how sensation and outputs need to match up, and just even the words making sense and lunatic. I love this. This is one of my favorite conversations. I think this has been brilliant. In respect for our time, we'll have you back on to talk about what can we do about it? How can we identify some of these patterns that people are experiencing where vestibular and autonomic issues and concussion, and what's actually happening there and what can be done about it. So we'll definitely have to plan that one out in the next few months. And
this
in the
is
meantime,
part one.
This is part one for sure.
Awesome.
For sure.
Well, I'm up for part 100 if you want to do it. This is a lot of fun. I enjoy you guys. I enjoy our company. We jive back and forth, and it's a very, very easy conversation. And I think we do explore some interesting territories. So we can continue to do that.
Definitely. We will definitely have you back. Thank you so much for joining us. For everybody who got to this point in the podcast, thank you so much for listening. Share this episode with one person who you think would find this conversation incredibly interesting. Somebody who may be dealing with some neurological issues or some unexplained, quote unquote, unexplained symptoms of a disease that they don't know what's really going on. And maybe there's some issues on the neurological side that may be actually playing a much bigger role than they once thought possible. Thank you so much again, Dr. Antonucci and JP. We'll see you guys soon. And to all the listeners, we'll catch you all on the next one.